All right, this module is about joints. And let's look at the learning objectives. Again, your study guide for the exam. Joints, or what we call articulations, are locations where bones meet. If you look at the diagram on your right, those are some of the main joints, but don't think that those are the only joints of the body. There's many joints in different areas with different levels of mobility. Functions of joint, yeah, connecting bones together and then allowing body movement. And they can be classified in two ways. There's two systems for classifying joints. They have a structural system and how bone basically which has to do with how bones interact. And then there's a functional system that has to do with the mobility of the joints. This table here summarizes the two classification systems that we use. So when we look at functional, the amount of movement essentially. So you have synarthrosis. Basically, there's no movement. If you look at the sutures on your cranial bones, right? There's no articulation there. There's no actual movement. That's an example. Then we have amphiarthrosis, where there is slight movement. And then we have diarthrosis, which is free movement, which is typically when we think about joints. Hey, I have a pain in my joints, right? My knees, my elbows, the shoulders, right? Those are examples of diarthrosis. When we look at the structural classification, which is how the bones are held together, we have fibrous, which is dense collagen, so collagen fibers holding together. Then we have cartilaginous, uh, and then we have what we call synovial, which involves ligament. Notice that all synovial joints are classified functionally as diarthrosis. If it's a synovial joint, this one in which we have ligaments and we have a lot of movement, we have free movement. We're going to come back to some of these and elaborate on them, the specific names that we see inside the table. This slide here repeats essentially the functional classification of joints with some good examples for them. So if you look at synarthrosis, again, immovable joints, we have your cranial bone sutures, as you see here in the diagram. Then also your teeth, right? They're basically locked into place into your upper jaw and lower jaw. Yeah, your lower jaw moves up and down, which will move your teeth, but the teeth themselves, as they articulate with the lower jaw, there's no movement there. We have an example of an amphiarthrosis, which is your pubic symphysis, where your pubic bone closes up. We have fibrous cartilage there. There's a little bit of movement there, but very little. And then, well, for diarthrosis, again, these are the freely movable joints. So this is typically what comes to mind when you're thinking in terms of joints. Let's look at the structural classification of joints, the different categories, one by one. So we have fibrous joints, are bones connected with collagen fibers. And these are going to be functionally either amphiarthrosis or synarthrosis. Type 1 for fibrous joints, we have sutures. I already talked about this, right? So between skull bones, synarthrosis level of movement, so no movement. Then we have gymphosis, also mentioned this one, between the roots and sockets for your teeth. This is also synarthrosis. And then syndesmosis, the location here is between the radius and the ulna on your arms, and then the tibia and the fibula on your legs. And in both cases, for example, the radius and the ulna, these are two bones that run in parallel. Same for the tibia and the fibula. And there is a small level of movement between the two relative to each other, essentially. And this would be amphiarthrosis type of. Looking now at cartilaginous joints. These are bones made of bones that are connected with cartilage. And these are going to be either amphiarthrosis or synarthrosis. Type 1 is what we call synchondrosis. The location here is the epiphyseal plate. We talked about the epiphyseal plate in the bone physiology chapter. This is basically where long bones grow. And then also attaching rib number 1 to the sternum. Movement level is, synarthrosis, no movement. And then we have symphysis. The location is between vertebra, what we call the intervertebral disc, and then between the halves of the hips, what we call the pubic symphysis. The level of movement here is amphiarthrosis. And finally, we have synovial joints. These are the most complex, the most movable joints. There's a lot of features in it. For example, we have what we call the articular cartilage, which is hyaline cartilage that is covering the bony surfaces. We have the joint cavity, which is a space filled with synovial fluid. So this is one example of a joint in which we have a special kind of fluid associated to it. The synovial fluid reduces friction and also feeds the chondrocytes, provides nutrients to the chondrocytes. Remember, the chondrocytes are mature cartilage cells. Then we have the articular capsule. We have here made of three components, essentially. The fibrous capsule, which holds bones together. The synovial membrane, which ends up producing the synovial fluid. The internal capsule, then, which has no nerves. Pain reception is all external to your synovial joints. Then we have that these joints are reinforced by ligaments, which strengthen the joint overall. And we have nerves and blood vessels, which monitor pressure and monitor also position, and then also provide nutrition. We have here some support structures of synovial joints. We have here that they use bursae and tendon sheets to reduce friction or pressure. Bursae are just fluid-filled connective tissue sacs. These can get inflamed, producing what we call a bursitis. They get inflamed, they collect fluid. There's a lot of swelling when you have a bursitis, lots of pain. Then we have tendon sheets, which are a type of bursae, but they surround tendons. These support structures are found where soft tissue rubs each other, or where it might be rubbing hard tissues. They do not provide structural support itself like other accessory structures like bones, ligaments, tendons, muscles, and even fat pads. So it's basically just, again, reducing friction or pressure when it comes to these support structures. Now, we can also classify synovial joints in terms of how much mobility they provide. We have here that the structure of a synovial joint determines how many directions it can move in. So if we start with the first one, we have plane joints, which are non-axial type of movement, so only gliding movements. If you look at the diagram, you might have to zoom in the PowerPoint. It's referring to the intervertebral disc. So your vertebrae relative to each other, there's some slight gliding movement there. So those are plane joints, non-axial. Then we have hinge joints and pivot joints, which are uniaxial. There's only one axis for movement. The diagram here is indicating the knee. That's a good example. Then we have biaxial. We have here condylar joints and saddle joints. And the example that we see here is the wrist, movement along, again, two axes if it's biaxial. And then we have ball and socket joints, which are multiaxial. We have movement along three axes. The example that we have here is the shoulders. And I talked about in the context of the pelvic girdle and your pelvis, your pectoral girdle and your pelvic girdle, the differences in terms of mobility and how there's a relationship between, an inverse relationship between mobility and stability. The greater the mobility, the less the stability. So we have here the example for that ball and socket joints, multi-axial, again, three axes in this case, is your shoulder. It's indicating your shoulder. So that's perhaps your most movable joint. At the same time, it makes your shoulders fairly unstable, which is why it's very easy to dislocate your shoulder. The next few slides gives you more examples for each one of these types of joints, synovial joints, when it comes to movement. And this is stuff that you have to memorize, the examples specifically. So I'm not going to read the slides just because this is just strict memorization out of the slides. Okay. We have more information here about how synovial joints move, sort of like a classification for the different ways a joint can move. So we have, for example, gliding movement, where two bones slide past each other. We have angular movements, the angle between two bones increases or decreases. And then we have rotational movement. A bone rotates around its axis. And then we have special movements. Now we're going to elaborate on each one of these. The next few slides have additional terminology about synovial joint movements related to the classification that we just saw. I'm going to ask you to pay special attention to what we have on the top right, which is basically telling you in which category these movements fall. Like right now, if you look at this slide, this is under angular movement. And this is self-explanatory, plus the diagrams are fairly good as far as understanding these type of movements. So I'm just going to go through the slides, and I'm not necessarily going to be reading this information for you. You do have to memorize it. I'll stop here and clarify this one, or maybe help you with a way of memorizing or seeing the difference between these two, because these are two very similar terms as we see here. Abduction and then adduction. Okay, if it's abduction, moving a structure away from the midline of the body. If it's adduction, it's the opposite, moving a structure towards the middle of the body. Now, you've heard the term abduction, right? Child abduction, or well, maybe alien abduction, right? And when we say abduction, child abduction, or alien abduction, someone taking a child away, or aliens taking a person away, right? So that's a good way of memorizing. Abduction with a B means moving away, in this case, from the midline of the body. Medial rotation, lateral rotation. Again, it should be fairly self-explanatory. Read the text, look at the diagram. If you have questions, ask me or ask one of the TAs. And then we have the special movements. There's some lots of terminology here: pronation, supination, plantar flexion, dorsiflexion, inversion, eversion. Okay. More special movements here: protraction, retraction, elevation, depression, opposition. Again, the text in the diagrams should suffice. We do want you guys to learn this terminology, though. The next few slides are about disorders of your synovial joints. You're probably aware of the fact that you can tear your cartilages, especially in your knees. The meniscus, right? That's a cartilage that it's very easy to tear, to damage. It's a very common sport injury to tear your meniscus, or your menisci in plural, or well, you probably heard also, for example, ACL injuries, your anterior cruciate ligament. That's another bad knee injury that we see in people that play sports, especially professionally. Okay. Yeah, cartilage tears can be fixed. You can get a surgery to fix your cartilage or to fix your ACL. But if you have recurring injuries later in life, you might be a candidate for a knee replacement. Then we have bursitis and tendonitis. I talked about bursitis, right? This occurs when the bursa near the synovial joints become inflamed and swollen, and it can be fairly dramatic. As you can see in the picture, we can see a knee that is super swollen, and that's just because of the inflamed bursitis. Or when we have tendonitis, occurs when a tendon or its tendon sheets become inflamed and swollen. The elbow, for example, is it's a joint that it's easy to get a tendonitis. We call tennis elbow. Then we can have sprains or dislocations. Sprains occur when ligaments are stretched out or torn. And then dislocations occur when bones are forced out of their normal alignment. I mentioned shoulders, right? You can dislocate your shoulders relatively easily. Very painful. I've dislocated my left shoulder quite a few times. You can also dislocate a finger, right? Or you could dislocate an ankle. And when you dislocate your shoulder, your ankle, your fingers, these just have to be repositioned. Once you reposition them, then they heal fairly well. They might be a little weak. My shoulder is from dislocating it many times is fairly weak, so I have to be careful. But typically, once you reposition the bone, you put it back into alignment. Basically, at that point, the pain disappears fairly quickly. Then we have arthritis, which is the most common kind. No. We have arthritis, for which we have osteoarthritis, which is the most common kind of arthritis. We have here that by age 80, most people have some osteoarthritis symptoms. In osteoarthritis, the articular cartilage softens and degenerates. The joints start making a crunching sound that we call crepitus. And then bone spurs develop on the exposed bone tissue. This is caused by years of joint wear and tear. It develops slowly and irreversibly. And then we have what we call rheumatoid arthritis. And this is an autoimmune form of arthritis. So in this case, cells from your immune system end up basically attacking your joints, your synovial joints, and your cartilage gets broken down. You have scar tissue that replaces it. Then you have ossification that leads to deformed joints. This type of arthritis is treated with immunosuppressants, like pretty much all autoimmune disorders. Quite often the treatment is immunosuppressants, anti-inflammatory medications like steroids, for example, and then pain medications. Then we have gouty arthritis, which is caused by uric acid crystals in the joints. This is a metabolic problem, a metabolic disease. Normally, uric acid is excreted in the urine, but if the levels are too high, then they form these needles, these crystal needles inside the joints that create a lot of pain. Then your immune system attacks the crystals in the joints. This leads to pain. This immobilizes the joints. This damages the joints. How do we treat this? Well, we also use anti-inflammatory medications. And patients with gouty arthritis are recommended increase water consumption to dilute basically the uric acid levels. This final slide here just summarizes the different type of joint disorders, some of which we've discussed, others we won't. We can classify them into autoimmune diseases like rheumatoid arthritis, but then we have, for example, lupus, another well-known autoimmune disease. Trauma, when it comes to dislocation and fractures. Then we have also genetic abnormalities like gout, which is, like I said, is a metabolic disease produced by a genetic abnormality. Then we have infections that can also affect the joints. And then, well, the aging process as we get older, osteoarthritis becomes fairly common.